Hello, everyone. Good morning, good afternoon, good evening. I hope you can see me. Welcome to this HSR session on adjusting purchasing arrangements to support the COVID-19 response. My name is Nirmala Ravishankar, and I'm a program director at ThinkWell. And ThinkWell is jointly organizing this session with the World Health Organization. About a year ago, when COVID 19 started, as you all will remember very clearly, governments around the world were working on a range of issues all at the same time to respond to the COVID 19 pandemic. And a large part of that response was focused on thinking through how to quickly adjust service delivery arrangements to respond to the dire need for COVID 19 testing and treatment, and at the same time maintain essential health services. And that was on the service delivery side of the equation. To support that service delivery rearrangements, there was also a need to look at the health financing aspects of the system to support all those adjustments. And the health financing aspects had both an element of bringing more resources into the sector to address the pandemic and this emerging and urgent need for resources, and how those resources flow to providers of health services. And it's that second piece which is about purchasing. So purchasing is by definition the allocation of pooled resources to providers of health services, both public and private, and how governments adjusted those arrangements to channel resources to frontline providers to respond to both the need for COVID 19 services and maintaining essential health services during the pandemic. Those adjustments to purchasing arrangements is the topic that we're going to be discussing during this session today. And to do that, we have a packed agenda and some incredible presentations lined up for all of you. After my brief introduction, Dr. Inka Matawa is going to be providing an overview, reporting a global study, results from a global study about purchasing arrangements. And then we'll be hearing from 3 different country speakers, offering a country perspective on how these arrangements have adjusted, how they've worked, what have been some of the innovations, as well as some of the challenges from the country perspective. Then we're going to be taking a short break from the speakers to take questions from the audience, any comments and questions from all of you. And then we'll be hearing a different perspective from Trin Habish from the World Health Organization again, who'll be offering a perspective drawing from the experiences in Europe to also comment on what the speakers will be sharing. And then we'll go back to an open discussion with all of you chiming in with questions and comments. And we really are looking forward to a lively debate and engagement on this topic. So let me just take another quick minute to tell you who all our speakers are. So providing that global overview, we have Dr. Inka Matawa, who's a senior health financing specialist at the Department of Health Systems Governance and Financing at the World Health Organization in Geneva. She has over 20 years of experience leading global work on strategic purchasing for UHC, with a focus on mixed provider payment systems and governance arrangements for purchasing. So no better person to talk to us about purchasing arrangements for COVID-19 services. Her work has involved technical support and policy advice to numerous countries and various regions, as well as conceptual work to synthesize evidence on what works for UHC and capacity strengthening activities. So Inka is going to be providing that global overview, followed by 3 country speakers. And so it's my pleasure to introduce those 3 country speakers. Dr. Mel Santillan is a medical officer from the PhilHealth, so Philippines' National Health Insurance Program, which is operated by the Philippine Health Insurance Corporation, or PhilHealth. She's a licensed medical physician with a specialization in pediatric medicine and with almost 20 years of experience in health policy research relevant to healthcare financing. She was also, very germane to this session today, the technical lead for costing, provider payment design, and development of a benefit package for COVID-19 related services within PhilHealth. So we're going to be hearing from her about the Philippines' response to COVID-19 and the PhilHealth journey through the pandemic. And then next up, we're going to be hearing from Dr. Martin Sabignoso, who's a health financing expert. He was deputy minister until recently at the National Ministry of Health in Argentina. And so he was the deputy minister throughout all of last year as we were all making these adjustments for COVID-19. He's also been a senior advisor for the Inter-American Development Bank on health financing reforms, intergovernmental transfers, and strategic health purchasing schemes. He's also served as a consultant of the Department of Health Systems Governance and Financing at WHO. He's the former CEO of Plan Nacer and Programa Sumar in Argentina, which is an innovative, large-scale, results-based financing scheme and has been leveraged in the COVID-19 response. So we're going to be hearing from him about Argentina's experience in doing that. Finally, amongst our country speakers is Salamao Lorenco, who's a PFM expert based in Mozambique. He works with ThinkWell. He's a senior program manager who's embedded within the Ministry of Health to support them in a range of PFM related functions. And in the context of the pandemic, his support has been around tracking and reporting COVID-19 funds, the allocation of COVID-19 funds. And so he'll be sharing his experience and the Ministry of Health's experience from Mozambique. And last but not least, we have Trin Hebish, who's a senior health economist at the Barcelona Office for Health Systems Strengthening of the World Health Organization Regional Office for Europe. Previously, she worked in the Ministry of Social Affairs and Health Insurance Fund in Estonia. Her work has been mainly focused on all aspects of health system financing, including the development of different payment and contracting schemes for healthcare providers, but also enhancement of healthcare quality assurance systems and transforming hospital and primary healthcare provider networks. And so she's going to be responding to the country perspective, also drawing on the experience of other countries in the region that she works in. So without any further ado, I'm going to invite Inka to set the stage based on the global study that WHO did last year. Over to you, Inka.
Good morning, good afternoon, and good evening. Thank you very much, Nirmala, for this very nice introduction. So, as we have heard, purchasing arrangements are critical in the reconfiguration of service provision to support the COVID-19 health sector response. And as part of that response, many countries had to and actually did modify the purchasing arrangements. So in this presentation, I would like to reiterate some critical purchasing actions, purchasing priorities to support the response to the COVID-19 crisis, and also give a short summary, a mini summary of country policies based on this survey. But I also want to outline what steps are next potentially and take on a forward-looking perspective. So the next slide, please. So these priority actions, as we propose them, they are based on an earlier blog, but as we have seen throughout this year, this is still very relevant. And then second, as I say, presenting a few findings from the survey. Let me also acknowledge the joint work on that together with Fadi Dihmi and Matt Townsend as we have put together this report. So for the survey, we covered 31 low and middle income countries. Half of them are from the Afro region, about a quarter from the Western Pacific and Southeast Asian region, and then followed about a fifth or so from the Eastern Mediterranean region. This was done by a Lime survey mid last year. And so now let me go into a few key points. So next slide, please. So indeed, we were interested in the following issues, basically the key issues that make up purchasing. First, how have purchasers coped with the increased needs for funding to assist with the COVID-19 response? Then, what adjustments have been made in the number of key areas, namely benefit and cost sharing mechanisms, payment methods, contracting arrangements, governance arrangements, and information management systems? And last but not least, we asked the respondents about what they take as lessons for the future. In fact, I'm not going to go into all of these aspects outlined here. We have some extremely interesting country inputs provided here, as well as our discussant. So I'll just pick on a few of these. The next slide, please. So let me look right away into the key adjustments undertaken. That's the expansion of benefits. And in fact, as we have seen, it has been critical to specify and or add the COVID-19 specific health services to the benefit package to actually allow the resources to be used and to be spent on COVID-19 cases. The red parts here in the box it refers to the priority actions as we propose them, and the blue parts is basically the summary from the survey. And indeed, what we see is that nearly all countries did expand and included COVID-19 health services in the publicly funded benefits. So that was basically testing, hospitalization, and medication. So these are the bottom three bars here. The blue part is really what was already in the package. The orange color here are the countries that have actually expanded their benefit package. And so we see that the majority of countries had it or actually expanded their benefit package. With respect to home-based care and teleconsultation, these are the top two bars here in the graph, actually was a much smaller number that had included that in the benefit package. Although, as said, the survey is from last year, and since then we have seen more countries actually including this in the package. Next slide, please. Now, one of the key policy recommendations, also as outlined in various WHO health financing publications, was that all co-payments and user fees for all patients should be suspended, at least for a defined period of time, to provide financial access to COVID-19 healthcare services, as well as to non-COVID-19 health services, basically the other essential services. The reason for that is that if people believe or are unsure whether or not they will have to pay user fees for healthcare, they may actually delay or possibly forgo seeking care. And that makes controlling the pandemic much harder and also puts more people at risk. So obviously, this requires additional resources to compensate providers for lost user fees revenues to keep them operational. And on my next slide, I will actually come back to that point. But indeed, for the majority of countries, the coverage of COVID-19 related health services, testing, medicines, and hospital treatments was actually mandated to be provided free of charge in public facilities. In many countries, this decision on benefit package was quickly taken. In other countries, purchasers have actually taken a bit more time to recognize that need and have eventually expanded the package. Next slide, please. So here we come to talk about a key adjustment in purchasing arrangements, namely the payment methods. And this was a very critical element in the policy responses. It is clear and became even clearer that in a pandemic, purchasers need to very quickly provide additional funds to providers because the providers are faced with increased expenditure, with increased costs potentially for a variety of reasons that I cannot go into here. And also they often faced reduced revenues. And so one critical action is to amend payment methods and payment rates to incentivize the existing as well as new service delivery arrangements. Moreover, providers, especially hospitals that are paid on the basis of fee-for-service or case-based payment, have been suffering from severe cash flow problems and revenue losses, especially when elective and other non-urgent medical care was postponed, as we have seen in many countries. And so this clearly calls for a shift to advance payments, for example, by providing a budget upfront to providers against anticipated claims, and that could be based on some increase over historical utilization levels. And I think we will hear more about that by subsequent speakers and discuss it. Now, in the survey, what we have seen amongst countries is that, yes, of course, indeed, numerous countries introduced changes in payment methods. So they set new payments for COVID-19 health services. They also allowed providers to use the funds in a more flexible way. Budget caps were temporarily lifted. And interestingly, actually, in two-thirds of the countries in this survey, financial incentives to motivate health staff working in difficult circumstances were provided. Also, a couple of countries provided payments or incentives to increase the ICU bed capacity. Next slide, please. So yes, more details on the payment methods as well as on contracting arrangements and information management governance can be found in the report. I'll put the link again in the chat here. But let me provide a few conclusions and lessons. First, importantly, as we have seen, practically all countries have adjusted their purchasing arrangements. Obviously, this was decisive to drive the response to the COVID-19 pandemic and to support the reconfiguration and reorganization of health services. So in a way, that reconfiguration and reorganization of service delivery had to go hand in hand and to be aligned with the purchasing adjustments. But what became also clear, both from the service as well as from our country policy advisory work, is that for countries to be able to steer the response, functioning or more or less functioning purchasing modalities needed to be in place already, and they needed to be adaptable. Now, this appears obvious and self-evident, but of course, this has been a challenge in a number of countries. And to undertake these adjustments and to take impactful purchasing-related policy decisions, strong information management systems with appropriate data, as well as effective governance arrangements and decision-making processes are needed. Again, there's sort of a bit of a question mark around the role of separate purchasing agencies, so specifically health insurance agencies. How have they been actually involved and participated in decisions around purchasing adjustments? I guess that's still something we can explore further. Now, I think it was also remarkable to see how quickly these adjustments were actually undertaken in many countries. Some changes happened practically overnight. So it seems that these pandemic-driven adjustments have created room for innovation because of the pressure to adapt to changing needs. For example, some countries use this to enhance the engagement with the private sector. In others, the information management system got a boost. Or again, in many countries, teleconsultation was introduced very quickly. And so I think this actually provided a chance to increase efficiency and patient responsiveness. However, however, as we are synthesizing the evidence, there's still need to further document these adjustments made in purchasing to see what worked, how and why, so that we can learn for the future. And I think there are still many research questions and also issues maybe for the discussion later on here. So, for example, forward-looking, how best to pay hospitals for pandemic preparedness. I think this is still, an important question. Another one is, how has actually the COVID-19 pandemic enhanced other digitalization processes related to purchasing? Next slide, please. And in addition to the need for further documentation, I think it's also highly critical to evaluate the actual impact of adjustments in purchasing arrangements to see how effective they have been to support the COVID-19 response, as well as how have they been able to, contribute to the UHC objectives of equitable access, financial protection, and quality. Have these modifications actually made purchasing more strategic? So just to mention on the side, we are indeed engaging in a new co-learning project precisely on this question. So what have been the actual impacts? We have launched a new collectivity project And of course, we'd be happy to link up with other colleagues and practitioners around the world who pursue similar questions. So next slide, last slide. So thanks very much for your attention. And as I said, I really look forward to further exchanging with you.
Okay, I will present. Thank you very much to the organizers of the HSR panel session for the opportunity to share our experience in the Philippines. So can I have the first slide, please? In March 2020, Republic Act 11469 was signed into law. This is we call the Bayanihan to Heal as One Act, and this enabled the government to quickly reallocate resources for the COVID-19 response. Secondly, purchasing has to be developed for COVID-19 health services. So for the National Health Insurance Program, which PhilHealth administers, we expanded the current benefit packages to provide coverage for the continuum of care for COVID-19 that include SARS-CoV-2 testing, hospitalization, and community isolation. And to do this quickly, we needed to streamline the benefits development process and ensure that there was compliance to submission of data on hospital charges from government and private healthcare providers to enable us to improve the benefit packages as more data came in. Thirdly, to ensure that providers can deliver both COVID and non-COVID related services, we allowed automatic accreditation of providers based on facility licensing of the Department of Health. And fourthly, to ensure that facilities had the resources to deliver care, we have an existing policy on front loading of funds to healthcare providers for a limited period during natural calamities and fortuitous events such as typhoons, earthquakes, volcanic eruptions, and now for the COVID-19 pandemic, where funds are disbursed based on historical claims or accounts to enable the healthcare providers to operate and expand services. We also front-loaded funds to the Philippine Red Cross, which has the biggest testing capacity in the country, and this was negotiated and covered by a contract. Lastly, we had to ensure that Filipinos are immediately covered by the National Health Insurance Program by fast-tracking the implementation of the immediate eligibility policy that was mandated by the Universal Healthcare Law. Now, in terms of the information management systems, can we have the next slide, please? We want to highlight that good information management systems are key in being able to be agile in terms of benefits development. So we use the existing e-claim system of PhilHealth for COVID-19 claims processing. However, adjustments were made to enable hospitals to submit billing charges that contain patient-level information on services provided, which were very important for us to be able to do the necessary adjustments in costing of the benefit packages and other improvements. And also the Department of Health also introduced a new information management system which complemented existing systems to strengthen disease monitoring and surveillance. So somehow this pandemic offered an opportunity to improve these systems for more efficient purchasing of health services. Next slide, please. So a year after the start of the pandemic, we can say that all the adjustments in purchasing arrangements during the COVID-19 pandemic offered us lessons to improve our purchasing. One is we have to ensure that there was adequate funding that is available when needed, and especially during this time of an emergency. And in terms of benefit package development, we had to streamline the long process, especially approval process, and facilitate These processes without compromising rigor by closely coordinating with the Health Technology Assessment Council, the medical societies, experts, and proactively work with stakeholders, including the private sector, and to ensure there was access to services, uninterrupted accreditation process was streamlined. And even with contentions to the front loading of funds to providers, lessons were collected from this experience so that PhilHealth can implement better provider payment mechanisms, especially capitation and global budget, because our goal is to ensure that resources are there when they are needed. Next slide. I guess that's my last slide. In terms of the medium to long-term implications on strategic purchasing, well, of course, COVID-19 slowed down our implementation of the financing reforms in the country that was mandated by the Universal Healthcare Law. Right now, impact on fiscal space of the country and PhilHealth is being assessed, especially in terms of impact on the assessment, expansion of benefit coverage. And the current capacity of staff and partners continue to be split between COVID and non-COVID related activities. And there exists some uncertainty because of the heightened political situation that hinders decision-making and implementation of reforms. However, this COVID-19 situation reaffirms the need to provide universal healthcare to every Filipino and that the role PhilHealth must play as the national purchaser. And additionally, the skills and lessons we have learned during COVID-19 in terms of moving forward to universal healthcare, for example, development or expansion of benefits, must always be guided by appraised evidence validated by experts. We were able to refine our costing methodologies, quick adjustments of package rates to reflect changes in the health market and standards of care while minimizing out-of-pocket payments. And it was really very important to engage the private sector. They really played a huge role in ensuring uninterrupted delivery of healthcare services. And most importantly is that all Filipinos are immediately covered by the National Health Insurance Program and be eligible to avail of the benefit packages so that they do not get impoverished in times of illness. So in a nutshell, I guess that is our experience in the Philippines. Thank you very much.
Good morning to everybody. Thanks to the organizers for this opportunity to share the experience of Argentina. So I will go directly to the next slide, please. As you may know, Argentina is a federal country and the Ministry of Health holds the stewardship role, and the provinces are in charge of providing, ensuring health services to their population. The system is composed of three subsystems: the public sector that covers people without formal health insurance, the social security sector, and the private sector. I will focus on the public sector, describing how a conditional budget transfer could become a powerful tool to encourage improvements in the purchasing function in a devolved setting like the Argentinian one, not only in normal times, but also in the middle of a pandemic. So, as I mentioned, Programa Sumar is a conditional budget transfer that aims at increasing access and quality of prioritized services for people without formal insurance by the public facilities through a twofold RBF, results-based financing mechanism. As you can see here in the slide, the Federation transfers additional resources to the provinces using a capitation payment based on performance. 40% of these transfers are linked to health outputs and outcomes that are measured for monthly, and the provinces have to co-finance 15% of this transfer. The provinces can only use this money to purchase a benefit package that is mainly integrated by preventive services using a fee-for-service payment mechanism. They can only hire, in principle, they can only hire public providers, and these public providers have autonomy to allocate the funds. It is the province or the municipality who defines the expenditure categories. So how was this scheme adapted during the pandemic? Well, in terms of the Federal Ministry of Health, we incorporated the population over 65 years of age, a highly vulnerable population. It represents approximately 300,000 people. We determined an increase of 285% of the capitation payment retroactive to January. We introduced changes on the performance retribution scheme. We use a continuous payment function with thresholds. So we decided that if you achieve as a province the first threshold, this achievement triggers the maximum retribution. We also created the National Equity Fund. I will come back later in the next slide with this issue. And in 2020, SUMAR executed 505% more than in 2019 in order to cope with these increased needs for funding. In terms of the province as the main purchaser, we expanded the benefit package for COVID-19 services, but we included also more than 100 services that refer to other prevalent pathologies. There was also an increase of, on average, 300% on the fee-for-service rates, retroactive to October 2019, in order to allocate more funds, to accelerate the transfer of funds for providers. We incorporated private, for the first time, private clinics and university health services facilities at the SUMAR network. And we supplement the fee-for-service mechanism with capitation payment in order to compensate the losses, the facility losses, and to quickly put money at the primary healthcare network. In terms of the provider, we allow provinces to execute 50% of provider funds centrally, creating like an emergency fund. It is a temporary measure. This could, we confirmed that was a good decision because it allowed provinces to accelerate the execution of funds. We eliminated the spending cap for human resources. The program only defines one single room, that is incentives to staff cannot exceed 50% of monthly payments to providers. The Federation also established a bonus payment for human resources, and of course, providers to receive this money needs to fulfill some reporting requirements, like registering suspected cases or positive cases in the National Surveillance Information System. I would like to emphasize that all these measures were fully implemented before June, when the accumulated cases, positive cases, were only 50,000 in the whole country. Today, we have more than 2 million positive cases. So we think that these measures were timely solutions for the provinces and for providers. Next, please. So I would like to give you more information about key adjustments like the health benefit package. We included testing and hospitalization services, of course, teleconsultation and home-based care. I would like to point out that we also include care services at nursing homes for residents. So for the first time, nursing homes are on the health radar, on the health system radar. This is a very good advantage, a very good opportunity that brought about the pandemic. And we also included the program SUMAR usually pays for non-traditional services like referrals, like notifications. We pay for reporting. So we included a set of services linked to notifications, for example, the notification of treatment of person with COVID-19, or the notification of suspected cases or persons diagnosed with COVID-19. We also pay for the notification of vaccination and for the active search for second dose vaccination. And we also included mental health teleconsultation and home follow-up consultations regarding mental health. And as I said, more than 100 services were also explicitly included to minimize side effects of other pathologies. Of course,
Martin, this is Nirmala. I'm so sorry to interrupt, but we probably have about a minute left, minute and a half.
Okay.
So if you wanted to talk about the Health Equity Fund or any key
yes,
element.
of course. Thanks.
Sorry about that.
And thanks a lot. So we also include the National Equity Fund to ensure the financing of COVID inpatient services in public hospitals and private clinics. There we have two ways of paying providers: by reimbursing the provinces or by direct payments that the Federation, the National Ministry of Health, can do with public and private providers. These providers must daily report the utilization of ICU beds through the interactive dashboard of the Ministry of Health. And these services and rates and user fee rules were also harmonized with the national social security sector. And we were happy to confirm that in many provinces, this financing mechanism became the key factor to develop one care pathway integrated by public and private providers. So next one, please. And the last slide. Some conclusions. Well, of course, the pandemic has been a unique opportunity to revalue the critical role of the strategic purchasing function, to ensure universal access and to reorient, reconfigure the health system response. We confirm again that it's not per capita payment versus fee for service, centralization versus decentralization, incentives versus training, strategic purchasing versus other functions. They're all useful measures and have more or less potential depending on the changing context, the evolving goals, and the pre-existing institutional and managerial capacities. And again, conditional budget transfer have also reaffirmed all their potential to coordinate and to improve the response of health systems in the evolved countries during a pandemic. They can align visions and actions, ensure sufficient and equitable funds among regions and provinces, and of course, they can incentivize changes in key functions as the strategic purchasing. Thanks a lot.
Thank you, Martin, and apologies for rushing you. I'm sure there'll be many questions for you. I myself have a few, so we'll come back to you before too long. Over to you, Salama.
Thank you. My name is Salomão Lourenço. Thanks for the opportunity to share with you a few insights of Mozambique. Next slide, please. Just to give a little bit of country context, Mozambique health system is dominated by public service delivery, which covers plus minus 90% of services. Health expenditure range from 8 to 10% as percentage of government expenditure, far from meeting Abuja Declaration, in which countries are committed to allocate 15% of its budget to health. In terms of challenges are quite clear in terms of having an adequate health financing in place. If we look at the results of the SARA survey of 2018, it shows clearly the low level of readiness of health system to respond to population needs. So basically, Mozambique entered the pandemic with inadequate supply of health services. Next slide, please. Mozambique is currently facing the second wave of COVID that has more cases in comparison with the first wave. In terms of health financing response, the National Operation Plan that was prepared showed an estimated need of $260 million in terms of resources, in which 40% was put available for the Ministry of Health. Part of this money was at the Ministry of Health discretion and was used to transfer to provinces slash service providers based on the needs in the light of the operational plan. Next slide, please. This slide shows that the pandemic has brought to light issues of donors' dependency and different mechanisms on how funds have been put available for the Ministry of Health. We can see that basically the donor support was in three different ways. The disbursement to Ministry of Health bank accounts was also monies put available through donor payment mechanisms and also in kinds. And this, of course, has had a lot of impact in terms of performance of health financing functions, specifically in terms of the purchasing. Next slide, please. In terms of key implication, this is my last slide. In normal course, the Ministry of Economy and Finance is one of the key purchasers of health services. But with the pandemic, the Ministry of Health gained greater decision-making power over funds made available for health. So basically the role of the Ministry of Economy and Finance was more of resources mobilization with a minimum intervention and allocation. So the allocation of funds made available in the Ministry of Health was in most cases in the Ministry of Health discretion. Another health financing change in the course of the pandemic is the use of a blend payment method. So in addition to the traditional payment method, which was basically the line item budget, the Ministry of Health also allocates funds not tied to budget lines, which offers some flexibility to provinces in the response to COVID demands. So basically, other than the traditional line item budget, also another payment method, that is the global budget, was used to attend the COVID demands. Of course, there are goods and bads about it in terms of, as we're looking for flexibility, that is a good thing for health. There are also the bad things about having the global budget available for province using this payment mechanism because of the accountability and reporting challenges that most of the case emerge in relation to this method. As Mozambique is decentralizing government functions, including health, the funds made available to provinces and facilities should be tied to programs, which of course reflect sector priorities, other than just being tied to inputs. So if they are located or if they are programmed tied to program specifics, so they will have to allow some flexibility in terms of the inputs. The pandemic and the ongoing reform on the planning and budgeting system can be a huge opportunity to put in place more adequate arrangements moving forward the universal health coverage. This is one takeaway that we have from this, as the government is both playing decentralization and reform on the PFM that will, of course, impact the way resources are put available for frontline providers. I'll stop here and will be available for the Q&A. Thank you.
Thank you so much, Salamau. That was fascinating. Actually, thank you to all the speakers. There we go. So I just wanted to abuse my prerogative as chair and pose a question actually to all three country speakers, and then I'll also quickly scan for other questions and come back to some of you after we hear from Trine. So the question I wanted to ask, I mean, across all three countries, we've heard about a lot of quick changes happening as demanded by the COVID-19 situation, resources, public resources moving to purchasers like PhilHealth and subnational governments, and those resources being channeled very quickly to providers. And so I wondered if the three of you could also reflect a bit on the governance arrangements and accountability for these funds. It's certainly an urgent crisis, and there's a dire need to respond really quickly. But in terms of accounting for how these funds have been spent, whether it's more budgetary allocations or front-loaded payments to providers, how are you seeing that aspect playing out in your three-country context? So let's start perhaps, actually, any of the speakers that want to speak to that question around governance and accountability.
I guess I have to go first. Well, for the Philippines, we still require our healthcare providers to submit their claims application. So whether it's a regular claim for COVID or it was front-loaded budget, they have to submit documentary requirements. And we have existing policy. However, we fast track. We have a fast lane for claims processing for COVID-19. So we pay hospitals faster than the regular claim. So in terms of governance, we have existing policies on claims processing, and also we have our fund management sector that monitors all front-loaded resources given to the healthcare providers last year. As of now, most of them are already accounted for, all front-loaded budget provided to them. It's just a matter of few claims that need to be liquidated from private providers. Thank you.
Thank you, Dr. Mel. Any thoughts from Martin or?
Yes.
Yes.
Yes, in the case of Argentina, we have some pre-existing rules, flexible rules and tools to incorporate immediately some new payment mechanisms or new services. We need it was needed to intensify the operational process with the provinces and with providers to present the new services, the new financing possibilities. That was the main challenge. It was not a governance challenge because we think that our rules were flexible enough to introduce and to adapt our strategy. You know that SUMAR program has been implemented in Argentina for the last 18 years. So, and it was a permanent, adjusted, and evolved strategy. So here at the national government and within the provinces and within the public network, we have enough experience to take advantage of those flexibilities and to react quickly to respond to this pandemic. Of course, we need to introduce some arrangements to incorporate private clinics, private facilities. because it was not so easy to incorporate them in some provinces. That's why in some provinces, private providers were contracted by the provinces, but in others were contracted by the national government. So here you see one of our flexibilities in order to ensure that we can work with the whole facilities that can contribute to this response. And of course, we needed to make some adjustments and to intensify the auditing process, because as these providers need to be accredited to be part of the SUMAR network, we needed to do these auditing and accreditation processes very quickly in order to start working with all of them. I stop here.
Thank you, Martin. Salomao, any reflections on this question?
Yes, well, in relation to Mozambique, let me say that the greatest majority of resources are centralized and are put available to the providers, to the frontline providers in kind. But the little resources that are normally put available to the frontline providers, they have to submit monthly reports on what they have spent, and the role of the Ministry of Health is to assure that those monies were spent in line with the priorities on national response plans. So it's the Ministry of Health primary role to go down to the province and make sure that the through the proper documentation, if these monies are being channeled to priorities. So basically, this is the arrangement, specific arrangement for in terms of accountability for COVID. But of course, there is the general processes, the general government processes of going through to how these funds were allocated and how they were used, if the procedures were properly followed. Thank you.
Fantastic. Thank you so much. I want to encourage everyone to post any questions they have, any comments in the live chat. But let me now throw this to Trine. We'd love to hear your thoughts. This has been a rich set of presentations. Any questions and, of course, reflections from your work in Europe would be fantastic to get into the mix over here. Thanks. Over to you.
Thank you so much, Nirmala, and hello to everyone. And then thank you for having me here. During the last year, so much has been happening, and health systems worldwide have had to respond to different challenges. Hospital services have to be restructured. Primary healthcare has been taking new roles. Elective care has been postponed, and usual patient pathways are modified to accommodate COVID-19 services in parallel with non-COVID-19 services. We have been witnessing very quick transformation of how healthcare services are delivered, and it all has implications for health service providers' income and expenditures. We may say that providers have experienced a dual shock, one on expenditure side and another one on revenue side. First, providers have been experiencing the increase of expenditures because of the substantial cost of care of treating COVID-19 patients who need long hospital stays, isolation, and intensive care. Providers have had to make substantial investments to expand the ICU capacity and workforce. Additional costs are also related to higher hygiene standards and use of PPEs and widespread testing. Second, in many countries where purchasing organizations use activity-based systems like case-based payment, fee-for-service, in these countries, healthcare providers lost their revenues because non-essential care was put on hold, and also people's care-seeking behavior changed. All this has not been taken into account by already existing provider payments. Therefore, as a response to the shock, we see that most of countries have adjusted their provider payment systems to mitigate this dual shock. And let me briefly summarize the key payment adjustments we have been seeing in WHO European region, where we have 53 member states. Many of them are high-income countries, but we also have many low-resource countries with very constrained health budget. And let me start with the revenue shock. We are used to talk about volume control mechanism, but last year, many countries and many providers experienced sharp drop in volume of care, resulting in significant revenue loss from provider perspective. The most common strategy to compensate the provider's loss of revenues has been to introduce some temporary new payments that fit into the overall payment system. In several countries, payment was changed from activity-based payment to lump sum payment based on previous year turnover. For example, in Bulgaria, specialists received up to 85% of usual income, regardless of the actual volume of care during 2020. Similar approaches were also used in many other countries to ensure that providers' fixed costs are covered. Another very important development has been the very rapid increase of remote consultations that was also mentioned by Inka. In many countries before the COVID-19 pandemic, purchasers paid only for face-to-face consultations. During the emergency situation, different remote modalities became acceptable and desirable due to safety reasons and being the only way how to secure, to some extent, continuity of care. But from the provider perspective, it has been also one way how to mitigate the risk of losing revenues. We saw that countries relaxed their outpatient visit standards, and the face-to-face fees were allowed to use for remote services, for example, like in Netherlands. In some cases, new fees were introduced. And maybe one thing what is important to highlight here is that in some countries, upfront investments were made available to scale up providers' telemedicine capacity. For example, in Estonia, providers received a one-time compensation to scale up activity for remote outpatient consultations. And then at the same time in Denmark, regions provided free equipment for video consultations. And let me now to continue with the expenditure shock. Another big change in payment systems was that countries had to make COVID-19 treatment-related adjustments. Most countries created new payments specific to COVID-19 services or patients. In inpatient settings, new payments aim to ensure preparedness, incentivize frontline health workforce, and provision of COVID-19 services. For example, Ukraine introduced additional salary bonus for staff taking care of COVID patients and additional intensive care preparedness lump sum payment. Some countries have been adjusting already existing case-based systems like, for example, Moldova and Kyrgyzstan. And this has been a continuous process to learn very quickly from experiences and to make necessary adjustments to take better into account actual cost of treating COVID patients, to segment payments taking into account severity of disease, and also to disincentivize hospitalization of mild cases. In addition, countries have been making upfront investments into equipment and facilities to scale up provider capacity to better COVID response. In lower income settings, these investments are often funded by donors. And in summary, let me also make 3 reflections how these developments may influence strategic purchasing reforms in low and middle income countries in medium and longer term. First and very important lesson has been that health system preparedness is crucial. And it also means that providers have to be prepared for any kind of emergencies, not only pandemics. From the strategic purchasing perspective, it is important to understand if our usual payment methods and ways of contracting providers incentivize providers to be prepared. We have witnessed a fascinating real-time showcase how quickly it is possible to transform model of care. Usually takes years, if not decades. Now we saw it happened almost overnight with remote services and also with COVID treatment. Many countries supported this transformation with upfront investments. Thus, The second reflection is that we should better learn the role of well-targeted upfront investments to fast-track reconfiguration of model of care. And my third and final reflection is the importance of data and monitoring if your payment system delivers what is expected. These very encouraging examples from Kyrgyzstan and Moldova, both lower middle income countries, show that it is possible almost in real time to analyze the COVID patients' profiles, cost structure, and to introduce necessary adjustments in payment system. So these were my three reflections, and thank you so much. Over to you.
Thank you, Trine. That's a great set of comments. And this question of how do you pay for preparedness, I really think is an important one and a challenging one for us to discuss. It seems like, it is not, when we work on strategic purchasing, we're trying to think about the usual set of issues under steady state. And it's only in the midst of a pandemic that you're suddenly responding, but how do you prepare for the next one? So thank you so much for that really interesting question. Now, if I could ask all the speakers to turn your cameras back on, let's see you all. And we have a few minutes to be able to discuss some of these interesting themes. And there's certainly been some common themes emerging across the three countries and Trine's comments as well. I wanted to start actually with you, Inka, to ask you, when you did this study and you found the results from all these different countries, was there anything that surprised you? I mean, you've been working in this field in purchasing for a long time. Were there aspects of the purchasing arrangements for COVID that surprised you, that you didn't expect to see in the results? So I'm going to give you a few minutes to think about that question and come back to you with that question. But in the meantime, I wanted to pick up on a theme that Trine brought up about information systems to look at what kinds of claims providers were making, to track needs. And I know this was a common theme in several of the presentations. Dr. Mel, you brought it up as well, the need for good, robust information. And I wondered if I could ask the three country speakers to speak a little bit about, we've talked a lot about innovations and new things that have happened. What have been some of the challenges in terms of the information systems that you're currently using? So reflect both on the challenges as well as new changes that have perhaps been inspired by COVID-19. And this time I maybe will go to Martin first to give Dr. Mel a few minutes to prepare, just to be fair. So over to you, Martin.
Thanks, Nirmala. Well, I think that the pandemic was the great opportunity to make interoperability a reality. It was an urgent need. There was an urgent need to have a good, basic, and manageable data to manage the pandemic. So in our case, as a federal country, it was critical to identify which provinces have their own systems in terms of surveillance or in terms of monitoring ICU beds occupation utilization, and then try to work intensively with them in order to interoperate these systems, the provincial ones, and to make the interface with the national one. And this was, I would say, a great success. We did it in a very short time. I think that in the last year we've been improving, and this was the key opportunity to concrete all these innovations that we always mention in every strategic purchasing panel or discussion. Of course, there are some operational challenges. First, we need to work with a simple, manageable set of variables. Then we need to place the right incentives at the right place. So in that sense, this connection between e-health agenda or interoperability or information systems and strategic purchasing was strengthened during the pandemic. And then it was very important, and one key challenge in our case was to work with private clinics, because they are not familiar with these public national systems, health information systems. So we orient our support mainly to private clinics, because the surveillance systems or the ICU bed systems must be utilized by more than 10,000 providers in our country. So that was a big challenge. But I think that these innovations, these great achievements now need to be reoriented to other pathologies, to other health problems, to other pandemics as the non-communicable diseases. So it is our opportunity. We need to take advantage of this opportunity to institutionalize, generalize, and expand all these innovations, not only for this kind of infectious diseases, but for all our health problems. I stop here.
Thank you, Martin. Salama, how about you? This issue of donor resources and the complicated landscape of financing a mix of on-budget and off-budget support. And I know you've been working for a while with the ministry on tracking these resources. Is there more work to be done? What would be the top sort of priority items to address as you think about preparing for a more resilient health system to be able to track these kinds of investments and what results the investments are delivering?
Thank you. Well, in relation to the COVID funding in the country, it's really interesting the way COVID has been bringing to light the need of having robust PFM systems as well as health financing functions in place. In relation specifically to the on or off budget, when we look at it, is that the great challenges that the sector have, that is not new, is not specific to COVID, but the COVID is just bringing it to light, is the lack of appropriate tracking of resources, because we have different frames of managing resources that are benefiting the health sector. We have the Ministry of Health on one side that has resource in the bank account, let me say that has like a full control of it. Then we have other resources that are on the partner's hand that they use, the Ministry of Health is the one that decides what to buy, but there is a lack of control in terms of information for appropriate reporting of this monies that are being used. And there is the third part that is even the more difficult one, is the in-kind. So based on our reports, the health sector benefits plus minus 20% of in-kind donations, and this is normally underreported. And the challenges are increasing because the greatest majority of resources that are being put available for the COVID are in kind, and also funds that are with partners. So if we look at what is available for the sector, is less than 25%. So there are great challenges in terms of having appropriate tracking, but of course, the good part of it is that the sector has some kind of flexibility in terms of using these resources to mitigate the COVID. But also there is these challenges in getting the appropriate tracking and getting the appropriate accountability of it. So it's basically this, what I can say for now. I'm going to stop here. Thank you.
Thank you, Salama. Over to you, Dr. Mel. I was particularly interested, and I think, Martin brought up this issue of interoperability between systems, and I was thinking in the Philippines case, you had mentioned before, you certainly have a good sense of what claims your providers are putting in, and you can track the flow of your funds to providers. But in terms of being able to triangulate between that and what the Department of Health or local governments are paying providers, especially in the public sector, how easy or difficult has that been to know what kind of resources, both financial and perhaps in kind, the way Salamau mentioned, what resources providers are getting from other purchasers?
Yes, it was difficult. Our existing electronic claims captures a set of defined data from hospitals. So when they submit claims to PhilHealth, they submit summarized statement of accounts. So we do not see much of the information that we need to quickly adjust our benefit packages. So during the pandemic, we needed more data, like because we want patients to have that protection. So we need to cost the benefit packages on the patient's perspective, on the member's perspective. So we did not use reference prices. We used billing charges, actual billing charges of patients, and we need those data. How much does a mechanical ventilator per day cost a patient? So we had to do something with our existing information management system to allow hospitals to submit billing charges every day at the start last year. So it was very difficult because talking to our IT people and having those adjustments approved at the level of the executive committee and by the board of directors of PhilHealth it's like going through the eye of a needle. So it was very difficult, and we don't have the budget immediately to allow us for that kind of adjustment. So it was difficult. So we had to do with our solve the problem using our existing resources. Our IT technical people were very accommodating because somehow we were able to collect the actual billing statements of patients, and hospitals were able to submit. However, we had to clean the data. We still had to do some more steps when the billing statements were submitted to PhilHealth. But at any rate, we were able to do some adjustments in terms of that. So it was difficult for us.
Fair enough. Okay, so I know we're going to run out of time soon, but Inka, I wanted to come back to you and get your sense of what surprised you from this study that you conducted now that you look back at the past year and the results you got from the survey.
Okay, yes, thanks a lot for this question. I mean, maybe it's not so much about what surprised me, but we got a lot of information in the survey responses on payment methods. And indeed, we have seen that, nearly all countries actually made adjustment to their payment system to get funds to the frontline providers. So that was very confirming, a very positive message to get out there. Same with respect to the benefit package expansion. We had much less information on two key aspects, namely the governance arrangements and information management systems. And in fact, Dr. Mel just spoke about that. So, if I may say so, even in the Philippines, with PhilHealth having a strong information management system, you were saying that, in fact, you didn't have enough information. And so I think that really reflects what a lot of countries actually experienced, that the information management system wasn't established in a way that it could quickly help policymakers, to sort of pull out the needed information to inform the COVID-19 health sector response. So what is it that countries have been doing? I mean, some countries integrated some of the reporting obligations into the existing information management system by tweaking sort of the existing modules. Zambia did that, or North Macedonia or Armenia. Other countries actually introduced a specific COVID-19 module within the existing health information system, or like in Myanmar, there was a new module within the DHIS2. And then a few other countries actually introduced a new or separate information management approach to complement the existing system. And so, in fact, actually, from the responses that we got, it seemed that rather the minority of countries were actually or had an information management system that was well established to produce the details that they wanted to support the contract tracing, for example, to have the patient records in place. So I think this just really confirms again the key message, or the key need for having good information management systems in place to support purchasing, generally speaking, but of course also in such a crisis. And maybe, if you allow, just one final point. I haven't been speaking about that in my presentation, but another aspect that we looked into was the engagement with the private sector. And as I said, half of the countries we had were from the African region. So there was actually, it seemed, not a lot of change in the contracting modalities with the private sector, because in fact, most of the COVID health services have been publicly provided. But of course, there was increasing demand. And so that private sector involvement actually had to be built up. So in some countries, the government explored how to formally include the private sector providers in the response, so how to integrate them in the provider network, with the idea of reducing or avoiding out-of-pocket expenditure. But I think there is still, for various reasons, for various regions, I think we can look further into, how the private sector has actually been engaged. But maybe I'll stop at this point, and thanks.
Thank you, Inka. Thank you. In fact, that was a point I was thinking about as well. I mean, I think from both Argentina and Philippines, we're hearing about COVID-19 driving some new thinking, innovation in terms of engaging with the private sector, and whether that's also been a common theme in other parts of the world, especially in Africa. I was wondering if we should be doing more work on that. So now, of course, we've gone slightly over, and I know we need to wrap up. So I'm just going to offer a few final reflections. This has been a really, really rich conversation, and I want to thank you all the speakers and all the attendees for joining. For this fascinating discussion. Just to wrap up, I think there are a few common themes that have emerged from all these discussions, and I just wanted to take a minute to reflect on a few of them. One, just the importance of purchasing. I mean, and when I think of folks on this call who have been working on purchasing arrangements, looking at studying purchasing arrangements, or indeed implementing purchasing arrangements and reforms to purchasing arrangements, the importance of that has been reiterated by the COVID-19 pandemic in a way that to me was somewhat surprising and new. It isn't just about some of the more standard issues that we've talked about for a while, about tracking provider performance or population needs, but also the adaptability and the agility of these purchasing arrangements to respond to a pandemic. And I think this issue, Trine, that you brought up, even as we think about payments, how do we pay for COVID preparedness or pandemic preparedness, forward-looking preparatory steps, both for the purchaser and through the purchaser for the provider? I think that's a fascinating issue that we as a group of experts and technical folks who work on purchasing, that's the challenge, to think through what we're learning from the pandemic. Which brings me to my second point, and I think this again reiterates some of the messages that Inka offered right at the beginning, the need to study more and understand more what's happening across different countries. And in as much as different countries have introduced new arrangements, have tweaked existing arrangements, I suspect the jury's still out in terms of what's worked and what's not. And so doing more learning to to document and understand what's worked and what's not is certainly a call to action for folks like us to continue working in that space. And then one final reflection, and I think it goes back to what several of you brought up, in as much as we think about the perspective of the purchasers, but also understanding the perspective of the providers, be they public providers or private providers, the kind of changes that COVID brought about, and I think, Trine, you brought this up, their regular payments going down, and yet the need for investments to prepare for COVID. So this double hit that many of the providers were facing, and purchasers being able to anticipate those needs better in the future. I feel like that's also a critical message for folks like us who work on purchasing arrangements and tend to sometimes focus on the purchasers and not perhaps pay as much detailed attention to providers. So let me stop there and once again just thank all the speakers who've joined from across the globe at different times of day and night, and all the attendees. Thank you all for joining and for staying a few minutes extra and participating in this session today. Thank you very much. And goodbye.
Okay.
Thank you.
Bye-bye.
Well, all the best to you. Until next time. Thank you.
Thank
Bye.
you.
Bye. Thanks.